Hello and welcome to the Auditing Antics podcast. So, Michelle, I feel like I'm finally, anyways, getting back into everything, getting my energy back, getting well rested after all. Go ahead.
I was just say it looked like fun.
Mhm.
I haven't been to an in-person AAPC event since like pre-COVID.
Same here.
My natural desire to not socialize has taken over and I attend virtually.
I know it's like COVID really helped us hermits out where we didn't have to put ourselves
Did
out there as much.
it though? Did it help us or did it enable a bad habit?
Yeah, I know. But it was nice, and that's one thing that they were talking about. The chapter was talking about how it has been hard to get people to come back out. Most meetings are virtual now, and I know my involvement with chapters is usually speaking for them. So it's been nice to have that open platform now where most chapters use Zoom or whatever platform they use,
Mm-hmm.
and we can meet more people, reach more people. The chapters look very different now than they used to because of that, but it was a lot of fun getting to meet some people here. I've been in Knoxville almost 7 years now, and I have not interacted locally in the coding community here. So that's been interesting, and great. It's nice to meet people that have the area in common. So what have you been up to, Michelle? I hear. Now, let me preface this for everybody. I told Michelle we were going to be given some life updates or just some little chit chat in the beginning, and she says, "Don't bring up the corn," but we have to bring up the corn, Michelle, because that is something that is unique to you that not a lot of people do because you love this corn so much.
Well,
So how many boxes or bushels or what do you call it?
they're called bushels.
Okay.
And I bought 2 bushels of corn to eat for the next year. And I convinced mom and dad that they needed to do the same thing. So we
So
had that
Michelle
project.
has gotten down the tips and tricks of is
Corn
it
freezing.
well corn freezing, but when you get the husk off. I was gonna say husking, but it's
Oh,
shucking the corn.
yeah. But you know what? I got a really bad blister from doing it my way. I guess I didn't account for the fact that I had only done that on like a maximum of 12 ears of corn in the past. So my tip or trick is have your husband husk the corn.
Yeah, there you go. That's perfect. That or kids, if you got kids around. I remember
Yep,
growing up, that was our Sunday afternoon duty after church. If we got
I
corn at the
know.
stand, we had to go out on the porch
I know, but
and take care of that.
it was worth it, I
Yeah.
would say. But
Yeah.
yeah, so now I have a whole year's worth of corn that I get to enjoy.
Yes. Yes. And Michelle's joined me on the sourdough journey. I shipped her and my sister in law little bits of my starter, and we weren't sure what was going to happen. I thought it would be okay,
Yeah,
but they both got it and it took right off. So now
yeah,
we're all going through that journey together.
yeah. So now my life revolves around this little container of flour and water on my counter that I don't know. I say it's kind of like when we used to have the Tamagotchis. You got to keep them alive. You got to
Yes.
keep this alive. Feed it every day. Discard. Clean
Yeah.
up after it so it doesn't get moldy.
It's like a little baby. Now, what did you name yours? Did you name it? Your
Yes, I
starter?
did. It's Danny DeVito.
I forgot it. Mine is Angela Lofsberry because I'm obsessed with Murder She Wrote and Angela Lounsbury. So yeah,
So we
that's
shouldn't eat your sourdough. Are you going to try to poison us with it, or
no, no, no.
okay, good.
It's not. It's not a murder loaf.
Or are you out there solving crimes with your bread?
Yes, yes. We'll look at it that way. I'm out there helping the community.
Solving the crime of who ate all the bread.
Exactly, exactly. All right, so today we're going to be talking about psych and neuropsych testing to continue in our mental health awareness month for May. And this is something, again, I feel like sometimes when we prep these topics, it's like, okay, well, what's so difficult about it? And the reality is it can go wrong in so many ways.
Yeah.
So for me, it helps to break down and look at testing, the assessments, whatever you want to call it, in different buckets, where we're first looking at the actual test administration portion. Then afterwards, we look at, the interpretation, everything that comes after. So with the testing, first, before I forget to say it, so we're talking about the CPT code category 96136 to 96139. So this is broken out with codes that represent the tests that are administered by the physician or qualified healthcare professional, and then also the technician. So, Michelle, I know just that particular component there on its own becomes very difficult for people to decipher.
Yeah, I think the biggest
Technician.
yeah, I think that's the biggest issue I see when I'm auditing is they don't know who is considered that other qualified healthcare professional. And so then we get into scenarios where they're billing the technician under the provider um, or qualified healthcare professional code when that's not supported.
And a lot of times too, it's driven because they want to bill it under whoever ordered it, and they're
Yeah,
not necessarily
that's
paying
a good point.
attention to who's doing what. And in this case, because we have the designation in the CPT code description, we have to make sure we understand that part of it.
Hmm.
Now, one thing that I've noticed over the years, I've worked with different organizations on this, and I've also done a lot of work with a company called Clinicom. And Clinicom is a great organization just for anyone out there who may be needing or wondering if there's different solutions related to assessments. They have essentially taken this and automated a lot of things, or maybe automated's not the right word because the patient does still go through and do all of the testing, but it's taken it from that, paper and pen process or pencil process. Well, no, let's not say pencil. We don't want to erase our answers. Our paper and pen process to an electronic version that can be transmitted to the patient. These services can be done via telehealth, so that makes it a little different
Hmm.
there when we're looking at, okay, who's administering. But they've set this up in a way where it really streamlines the process. It's electronic. It helps with the physicians and whoever may be going in to do the review of information, the interpretation. So I've seen a lot of great things come with Clinicom and in the way that they are integrating that into different organizations.
Hmm.
Now, with these services, and with that work that I've done with Clinicom, it's something that's important as well to think about payer specific policy because that QHP, that qualified healthcare professional, is always that outstanding question of what that means per each individual payer. And I bring that up because one of the things that I found in researching different states, especially different state Medicaid plans, is sometimes there's certain types of practitioners, like a licensed social worker, that we
Hmm.
wouldn't consider to be a QHP per AMA's definition, but per the policy, they're allowed to render those services and be the billable practitioner for the codes that represent physician and QHP.
Hmm.
So that is something that, like many other things, it's not one blanket answer across the board. We could say for CMS, definitely they're going to follow AMA. But when you're looking at whether or not, even if they're a licensed individual, if you can bill the 96136 and 37 for the physician and QHP, the payer policy is going to dictate that. Now, if you have a situation where you have someone who's a licensed practitioner, but they don't meet the definition of QHP, that's when you do have to bill the 96138 and 39, which represents the technician.
Mhm.
So a lot of little rules there. Like it's
Yeah,
kind of exhausting when you
yeah,
try to break that down every time.
yeah, and I can
Um,
see why that would be done incorrectly so easily because how many people want to create just like a standard of all of the services are going to be billed this way when this person does them, and you can't
right,
really do that because I'm sure there's a reimbursement difference between the two and you want to make sure you're maximizing your reimbursement, but then you get into situations where you might be billing that incorrectly to some payers. So
right, right.
interesting.
Yes. Now, the other two parts of this code, and I'll speak to the two or more tests. I'll let you speak to time because I know that's a pain point in audits. But do remember when we talk about this type of testing that there has to be two or more tests that are conducted. So when we
Hmm.
talk about those tests, sometimes I'll get asked, well, what specifically are the tests, things like that. And just think of it like we would with like the PHQ-9, the Vanderbilt test. There's all of these different tests that are called standardized testing that are looking for symptoms of, a particular condition to try to diagnose the patient and figure out a treatment plan. So we have to have a minimum of two tests that are completed in order to be eligible for these CPT codes. Now, that last part, Michelle, do you want to speak to that? Because I know for me, this can be a pain point in the audit process.
Yeah, so the second portion of that is these are also time-based codes. So you have to meet the time requirements to be able to bill for them. I know one of the biggest errors that I'm experiencing is you have pages and pages and pages of documentation of testing, interpretation. You can tell, like, wow, they spent a lot of time on this, but nowhere do they have a breakdown of how their time was spent. And
Mhm,
then they're billing all of these units of these codes, and it's like it's got to be somewhere. So you have to make sure that however time is being tracked for the administration, and things like that and scoring, that you are also making sure that that time tracking is showing up in the documentation, because that's just as important to be able to support billing.
mhm. Yeah, and it's really going to depend on how it's set up.
Hmm.
With that program I was talking about, Clinicon, that's another nice thing about the tools that they've built. The timing component is right in there.
Hmm.
So essentially,
That's
their
great.
system can create the report that's needed to cover all of these areas. But when there's not something like that that's built specifically for this, we're left to the paper process, which a lot of people are still doing that and scanning it
Hmm.
in to the EMR, or we're left with an EMR system having assessments loaded in, but then they're all individualized. It's not like you look at one document to
Yeah.
collectively see everything that goes along with it. So, time, you have to be very intentional with calculating the time and documenting the time in order to
Hmm.
report that correctly. Sometimes when I talk about the codes, people will be like, oh, it's a first 30 minutes, I just got to meet 16. I always meet at least 16. And it's like, okay, well, you're not documenting it. We have to see it.
Yeah, you have to tell us in order for us to know. We can't just
Mhm,
assume. And I think that is so true. But I also think workflows
mhm.
are causing an issue with the time documentation as well.
Well, it's funny you say that because when people first look to integrate these types of services into a practice, workflow is a big part where they're trying to think, okay, clinically, how does this make sense?
Yeah.
But then we also on this side have to think about supporting all the requirements. And something we didn't talk about yet is the medical necessity.
Yeah.
And, that's one thing I've had questions, and there's differing opinions out there. But if you are using a certain test, for example, and giving it to every patient across the board, regardless of who they are, what's going on, then that's going to be questionable why that particular patient needs that, especially if they're a new patient and you've not seen them yet. And
Mhm.
I've seen it happen in different ways where certain practices that I work with are specialized. So they already know from the requesting provider that that patient needs that type of testing done, and that definitely makes more sense. But if we have situations where, everybody in internal medicine is being tested to see if they have major depression or, whatever other kind of disorder there is, that's not going to make sense. And
Mhm.
it also reminds me too, not that I even know how this walk-in clinic was filling these things, but I
Oh
brought
boy.
my I brought my youngest daughter to a walk-in, I think it was last year, and we're going through the paperwork. I had her, filling it out. She needs to learn to do that on her own. Um, and we're looking at it, and all of a sudden I see a PHQ-9 and a GAD-7, and we were not there for anything even close to mental health related. So my question was, and they had said when they handed us the paperwork, oh, the things in the back there are just some additional questions as well.
Yeah.
And it's like, okay,
No,
so you want us to fill all of these out. What are you doing with it? You're not even
exactly.
using the data.
What was the
Or
purpose other than to
yeah,
say you did it and bill for it?
yes, yeah. So that was the time where it was an urgent care visit and we were self-pay. And I remember laughing and telling Michelle every test that they had to do and everything, the MA, he was the nicest guy, but he was always like, don't worry, that's included. You could tell that he got questioned quite a bit about their pricing
Yeah.
with every different test they were running. But
You
it,
kinda have to be on top of that these days. I mean,
yeah, yeah. So apparently they do the psych tests as well, just because. So there's got to be a purpose behind it. It can't just be handing these tests out to people for no reason. You do want to think about that if they're a new patient. What is prompting you? How do you even know that this is something that's appropriate? Because it's really broad. When we say two or
yeah.
more tests, it's up to the ordering practitioner to decide what tests are appropriate for the patient. So just think about that. I'm not going to get into the clinical arguments around what would work, what wouldn't work for a new patient, but it has to make sense at the end of the day.
Mhm. Yeah, you can't just throw every test in the book at them for
Yeah,
the sake of doing that. You have to have reasons.
yeah. And that, I know some of the standardized tests are called screening tools, but in my mind, how I try to separate those out is whether the patient is requiring screenings or do they need assessments. And
Yeah.
assessments, from my perspective, is when there are known issues, the patient, in a new patient situation, they're referred for a very specific problem, maybe even for potential treatment. Maybe they have something in mind before they come, the provider referring does.
Mhm.
So there's purpose there. It's not
Yeah.
just, oh, do you have these feelings? Like, yeah, we have these feelings. What are we going to do about it?
So I answered yes. Now what? But you still need to address my sore throat.
Yes. Yes, exactly.
You opened
Now,
that can of worms. That's your own problem.
yeah, I know. Do you
That's all
have an
I'm gonna
hour?
say. Oh, it'll
Oh,
be like
man.
that note I was reading that was like, this patient presented on a very busy Saturday to talk about anxiety. And it's like, why can't the patient come on a Saturday to talk about their anxiety? What does your schedule have anything to do with it? This poor person.
No,
It's like, that's the kind you
hopefully,
send right on in and say, why? Why is this even in the patient's note?
yeah. Well, and
You better
hopefully the
be
patient
questioning.
reads that and gets a new provider.
Yeah, that to me was the ultimate of terrible. But maybe they answered one of these questionnaires. Well, no, that was the reason they were there. But but I don't know.
Don't go for mental health on a weekend, I guess.
Yeah,
No,
Saturdays,
that's fake. That's not true. That is not true.
anytime you need help,
Yes. Yeah.
and don't let
Now,
somebody make you feel inconvenient for doing so.
Yes, exactly. 100%. And honestly, I joke about that with the questionnaires and urgent care. I really hope that that particular organization, it's one of those corporate urgent care centers. Hopefully they do look at those and do something with it if somebody's
Yeah.
struggling. Now, the second part of all of this, so we talked first about the administration. Now comes the actual evaluation portion of this. So we have 96130 and 31 for psych testing, and then we have 96132 and 33 for neuropsych. Now, these codes here, it's important to understand. I'm going to read through the list because this is all in the CPT code description. And
Hmm.
Michelle, I think from an audit perspective, this is where a lot of people get lost and they don't realize, oh, wait, we have to wait for all of these things to be done to bill for it.
Yeah, and I know this was when I first started auditing these types of services, it was extremely confusing to me. So I think
Mhm.
this is something where if you're going to be coding or doing anything related to these services, that you take the time to understand fully
Mhm.
when and what you're billing for.
Right. So first, these codes can only be performed and billed by a physician or QHP. And QHP here, qualified healthcare professional, means essentially somebody who is allowed to bill for an E&M service. So when we talked about QHP in terms of test administration, that is very different. So this one here, if they can bill an E&M service, then this is what we're looking at for the last portion. So this includes it says integration of patient data, interpretation of the standardized test results and clinical data, clinical decision making, treatment planning and report, and interactive feedback to the patient and or family members, whoever's there. So, Michelle, one thing that I find is when people do understand everything that's included and they, properly piece that apart, they also are confused because sometimes I'll see them trying to bill 96130 with 99214, for example. And the part that stands out to me in that description is where it says that it includes clinical decision making and the treatment planning. So that right there is our medical decision making. So we
Hmm.
don't have medical necessity or support for MDM apart from this CPT code here.
Yeah, and that was something that you and I had talked about before we did this episode. You had brought up the E&M billing, and I was like, well, I don't think I've ever seen an E&M reported for for these
Yeah.
services. So I found that really interesting, and you bring up an excellent point about it being included within
Mhm.
those codes, so you can't bill for both.
Right, right. And some just don't want to bill the 96130. Some choose to bill the level of service instead. But either way, that's the option. You have to look at capturing the review of the information and getting credit for the decisions that come after the tests are complete. Now, one of the things to think about is the timing of this as well. So if that review of the test and the interpretation and all of that comes like the day before the patient is met with, you have to think through all of that because this again is timed just like the testing codes are timed. So we have to have the first hour for the 96130 and then 96131 is for each additional hour after that. Now, do you have any other insight, Michelle? Are there any other areas you've seen in relation to this that, are deficient at times in audits?
No, I think we've touched on the areas that I see. The biggest areas of deficiency that I see is the time tracking, and
Mhm.
then not billing at the appropriate times, or billing before all of the elements are completed, like after they are interpreting the scoring and everything, but before they're having those feedback sessions with the patient.
Mhm. Yeah, and actually, I remember, and I don't remember the year, but when we had this code change, this code set change by AMA years ago, I remember the practices having a really hard time in their workflow because before they didn't have to wait all the way until the patient was met with again and they go through that process. And what they had to look into was things like how they're scheduling, or
Mhm.
is anybody even following up with the patient? Now with some of these things being done remotely through telehealth, you can have a situation where the patient either just isn't doing the tests or they've completed it and nobody's going back to follow up and see that it's done and then have them come back for that assessment. So you do have to be very careful to make sure that everybody within the practice understands how this code set works, because it's going to affect your administrative staff workflow and your clinical workflow as well. So you're
Mhm.
very right. You have to essentially hold the claim for the evaluation portion until all of those things in the description are complete. And then at that time, you can go ahead and bill.
Mhm.
I've had situations where patients, not patients, clients will say to me, well, what if we don't meet with the patient and the family afterwards? But then the question would be, okay, you want to go ahead and bill because you have a report and interpretation, but that's going to go back to questioning medical necessity.
Yeah,
If
why
you
was it
didn't need
needed?
to meet with them, right? Even if it's a referral, if you didn't need to meet with them to talk to them before they go back to their other practitioner, why was that done? How is it being used in the diagnosis and treatment of the patient?
Mhm. And I think that's actually an excellent point. There is, I think, so much focus is placed on the testing and scoring that we forget about the treatment plan and feedback to the patient.
Mhm. Yeah, it's got to come full circle.
Mhm.
So overall, we need to have everything from the tests that are rendered. So answers, questions, answers, scoring, all of that has to be something that can be recalled back out of the system in the event of an audit. So
Mhm.
everything that shows testing was complete, then you're going to have the separate report from that physician or APP practitioner who's reviewing it, they're interpreting it, they're making their clinical decisions, and they're coming up with a treatment plan to then review with the patient and or family, whatever that scenario is. So hopefully that clarifies it. I know one thing that's been confusing is some of the different types of practices that are not primarily behavioral health are starting to look into using different tools, especially in pediatrics. That's a huge one. So make sure that you dig in and remember, we've got to look to AMA at a base level. So something
Mhm.
as simple as a code description, all of those words are going to matter. It's not like it's a lay explanation, it is the code description. So we start there, then we layer payer on top, and then, make sure that all workflows are matching from there.
Mhm.
All right, now next week, Michelle, we're going to come back and we're going to round out the month of May with Q&A. So if anybody has any questions, feel free to send us your questions. You can message me through LinkedIn. You can put a comment on a post. This episode, you can comment on this episode. I'll get the notification. I also will put, if you watch us through LinkedIn, we have a separate event for the Q&A next week through
Mhm.
LinkedIn. So feel free. We do like them to be submitted before. We don't take the questions live on the air at that time and answer them, like that. But let us know before. There's lots of ways to reach out, and we would be happy to tackle whatever it is that you're going through.
Mhm.
All right. Well, I hope you all have a good rest of your week and Memorial Day. So I'm looking forward to the long weekend for sure. Have some rest and downtime. Hopefully not too much craziness getting ready for a barbecue or something. Michelle, you'll be having corn.
I'll bring the corn. Who says I want to share my corn? Okay.
I know.
I worked hard.
Yes. All right. Well, have a good week, and we will see you back next week for that last part of May.